Shawna, this is not our mother's menopause. Oh my gosh, we have so much more information now, and we have the perfect guest to help us.
I'm so excited to have Dr. Ardelle Piper, who is a Royal College certified OB-GYN and menopause pioneer, joining us for our podcast. We have so many questions. She's got the answers.
Let's dive in. Welcome to the Girls Talk Healthy Aging podcast, where we dive deep into pressing health and fitness issues facing aging women. I'm Alli Kerr.
And I'm Shawna Kaminski. And together we'll bring candid conversations, expert advice, and personal stories that will inspire and empower you on your own wellness journey. Dr. Piper, we are so thrilled that you are joining us on the podcast today.
I'm so thrilled to be invited. Thank you.
Dr. Piper, why did you choose to be an OB-GYN, and how has that evolved and your service changed as far as serving women over the past years?
Yeah. When I was in med school, it didn't take very long before I was really looking forward to the reproduction block. I went into med school thinking that I wanted to be either a family doctor or something that was kind of, holistic, and broad in its scope. But then as soon as we were learning about the digestive system and the heart and whatever, all of a sudden I was really interested in women's health. And I did a bit of shadowing and was really inspired by people who were delivering babies. I shadowed an oncologist who specialized in breast cancer. So that was, women all day long that she was chatting with. And I just realized that this really fit. There was a lot of broad areas that you could cover within women's health. So that really appealed to me. I like the idea of that focus. And so that's how I went into obstetrics and gynecology, which I thoroughly enjoyed. I really loved surgery. I really loved delivering babies. But when I was getting to the end of my program, I did a rotation in a menopause clinic, and same thing. It just clicked. It clicked with my education interests. It kind of clicked with my personality that's a bit more chatty and liking to understand people's stories and slowing things down a little bit. A lot of things fit. And so that's how I ended up deciding to come out to Ottawa and do a year of midlife women's health training after my OB-GYN residency was done. And then it just went from there. I started off doing what most menopause doctors unfortunately do, which is feeling at that time that you couldn't do full-time menopause. There wasn't enough volume, right? That was 2013 when really only high risk and extremely desperate women were being sent to the menopause clinic. And it's not seen as a specialty area. It doesn't have its own exam. It was kind of at that point, the underdog of gynecology. And so I was delivering babies at the same time and doing surgeries and such. And one thing led to another, and then the pandemic hit. And all of a sudden I realized that what I could do was telemedicine menopause consults. And since then, my practice has boomed. It's not all because of the pandemic and telemedicine. It's also because of, this better awareness all of a sudden of women's health. Some of the longer term research of the WHI coming out. Now menopause is being talked about everywhere. And so it was just, I think, it was fortunate for me that my training and my interests and then my telemedicine and then now the public interest kind of all just came together to lead me to what I'm doing now.
You mentioned the WHI and the study in air quotes that has really been damaging to women's health.
Yeah.
Tell us about that and how that's getting turned around.
Can we say what that is, what WHI stands for? Because some people may not know.
Yes. So the Women's Health Initiative is a study that the original data was published in 2002. It was a study that was designed in the late 90s to look at the longer term impacts of menopausal hormone therapy from a prevention perspective. So the back history of that is that hormone therapy, estrogen receptors were discovered, I think it was somewhere in the 40s and 50s. And then the appreciation of menopause being a low estrogen state, came shortly after that, realizing, of course, at that point when new pharmaceuticals were being designed, you can't get estrogen from people. That's not ethical to collect it from people. And so at that time, pharmaceuticals were very much based out of things from the environment. animals, plant products, etc. Right? That's how aspirin came around. And so Premarin, the original conjugated estrogen, was a hormone therapy that was harvested from animals, right? And so it was discovered that if you gave that to women, it would get rid of their hot flushes and night sweats. But then they didn't realize that the progesterone component is really important to keep your lining thin. So hormone therapy went out of favor somewhere in the 60s and 70s because people were getting uterine cancer from it. And then progesterone was discovered, and then sort of they revamped it. And so people in the 70s, 80s, 90s were getting increasingly comfortable and aware of menopausal hormone therapy, being prescribed it a lot. Some of it was a little bit questionable. Premarin was originally actually marketed to men. Don't you want your woman back? That whole feminine forever concept started around there of being, this is the fountain of youth. This can keep you from, not only hot flushing and such, but from wrinkling, from aging, from being cranky. It'll keep you wanting sex forever. Like there was a little bit of excessive, marketing there. But the truth is that it worked when it came to quality of life, right? So that was already being observed. But then the question was, well, what about people who haven't been on it? And there was a little bit of grumbling out there about, well, are there some breast cancer cases that we're now starting to see now that people are on it for a bit of time? And so the WHI was actually designed to test that. It wasn't giving hormone therapy to women who were newly menopausal, suffering with horrible symptoms. It was given to women who were intentionally not having symptoms, because if you enroll women in a study like this where you want to observe hormone therapy for like 5 or 10 years, they can't be having symptoms or they're going to drop out, right? So they intentionally looked for women who were into their menopause. So the average age was mid-60s. There were people enrolled who were even in their 70s. Some of them have been on hormone therapy. Some of them never had been. Some were obese, some were smokers. Like it was a big motley crew of thousands of women, which, really is great. Not having much for symptoms, and they put them onto what was the most common hormone therapy at the time in North America, which was the Premarin, the conjugated estrogen, and medroxyprogesterone acetate, or MPA, which is a synthetic. Again, I got to be careful about using the word synthetic because we're going to get to that when we talk about bioidenticals. It was a progestin, which does an effective job of keeping your lining thin, and that's why it was paired with Premarin at the time. So the intent was to follow people for 10 years to see what happens to their hearts, what happens to their bones, their breasts, etc. It was meant to be, let's look at hormone therapy and how it impacts people long term. And when they peeked at the results at 5 years, they saw this suggestion that maybe there was a few more breast cancers, a few more strokes and clots. And in a very strange fashion that has never been done before and never been done since, they decided to do a press release about this, pull the entire study, and it hit the news in this big fashion where actually, doctors didn't even have the journal in their mailboxes yet. It hit, they called a press release to say, we're seeing that hormone therapy is causing more breast cancers and clots, so we're stopping the study. Pandemonium, like all of a sudden women thought, this has been now actually killing me. What have my doctors been actually giving me? Doctors went, whoa, we thought that this was helpful. Now people are at increased risk of breast cancer from this. And so I don't think, and some other people on social media podcasts have talked about this, how the rate of fall of hormone therapy just dropped precipitously. And what ended up happening then in the 10 years after that is that women who did have horrible symptoms then started looking for other solutions, right? And that we'll get to that as to how then that sort of really fed the compounding industry and this concept of bioidentical. If what was causing the problems and all that bad press was Premarin and MPA, then you should come over here and use these things that are bioidentical, and we'll compound them for you. We'll individualize them for you. We'll give you exactly what you need. And this is safe. This is plant-based. This is natural. This will not give you risk. So that was also erroneous marketing, right? But it meant then that all those people who really were suffering looked for hormone therapy elsewhere because the doctors didn't want to prescribe it, right? Because people who wanted to be evidence-based doctors, when a big study like this comes out and tells you to be careful because you might be causing more harm than giving help, then doctors backed up, right? And what ended up happening then in the 10 years after that is that women who did have horrible symptoms then started looking for other solutions, right? And that we'll get to that as to how then that sort of really fed the compounding industry and this concept of bioidentical. If what was causing the problems and all that bad press was Premarin and MPA, then you should come over here and use these things that are bioidentical, and we'll compound them for you. We'll individualize them for you. We'll give you exactly what you need. And this is safe. This is plant-based. This is natural. This will not give you risk. So that was also erroneous marketing, right? And so it also meant that in those 10 years after the WHI, when everyone stopped using hormone therapy, we saw prescriptions for antidepressants go up. We saw prescriptions for bisphosphonates to protect against osteoporosis go up. We saw all sorts of other health problems increase in incidence and attempts at different types of therapies to try to treat them because everyone's going to go through menopause. So all these people who weren't been giving access to menopause therapy were looking elsewhere and for other things. So that's the kind of the Coles Notes version of the WHI. And that was published in 2002. So I did my menopause fellowship in 2013-14. And the first big conference I went to was the International Menopause Society meeting in Prague. That was in 2016. And the keynote speaker was one of the researchers from the WHI, who actually kind of gave the background story of how they, as the primary researchers, weren't really informed as to the intentions of the study protocol, that they were just going to drop everything. They were like, wait. We don't think that's the right conclusion to draw. Give us some time to look at the data that you're telling us about and give you some feedback. So they did, but it was smoke and mirrors. It was already decided that they were going to pull the study. So all of those people who were trying to enroll people and get good research, they were somewhat ignored when it came to their concerns about how this was going to be released and how this data was going to be interpreted. And so I was in the room. You could hear a pin drop. Like, all of these menopause doctors were just stunned at what a bad job this had been of how the WHI was released. And the long-term study of those patients was actually published in 2016. And that's where they then released some of that information, that if you divide the age groups of people, the younger women who were enrolled in that study didn't have the same problems with clot. The question of whether or not, is this because it was oral? Is this because these women were older? Was there a window of opportunity that was missed? Is it because of the progesterone? All of those questions have been now bigger parts of the research since. But the 2016 long-term results that suggested that hormone therapy is not toxic waste and going to kill everybody, that didn't make splashy headlines the way 2002 did. So we are still trying to catch up and correct the misinformation and disinformation that's out there, both in the public and in the physician community, because there are still tons of people. Like, this is all I do every day. I still get it in letters from doctors. I still hear it from clients themselves. Well, I've heard about hormone therapy and that it might help, but I don't want to get cancer, right? And so this connection between hormone therapy and cancer is such a difficult, complex, intertwined phobia that has developed because of this. And it's a lot of work to try to now undo this.
How much education do doctors get related to menopause?
Well, I think before, probably quite a bit, right? Like before the WHI, I think the stats are that somewhere around 40% of women were being prescribed hormone therapy. So before the WHI, I think it was pretty common to go into your family doctor's office and for them to be like, oh, hot flushes, night sweats, vaginal dryness, here, let's give you some hormone therapy. This will make you feel better, no problem. So, but with the WHI and everybody backing up, then it meant then that doctors were not really being trained and promoted to be prescribing hormone therapy because it was seen as something that was quite risky. And so I think what happened is over the kind of maybe the decade after 2002, it was just less and less sort of discussed about hormone therapy. I remember studying for my board exams, and what I thought was the most important thing to understand about menopause was the data, the differences in breast cancer rates between people who were on hormone therapy and not. Prevention about, osteoporosis, vaginal therapies, like those were all kind of like footnotes. And so I think overall, doctors like to learn about things that they can try to fix, right? And the physician community is very pathology focused, right? What has gone wrong with you? What can we help and try to fix, right? And so if menopause was then all of a sudden deemed as, well, I guess this is a natural phase that really ideally you try to go through, just like puberty. We don't try to fix puberty. right? We have interventions for pregnancies if people are having, bad symptoms like hyperemesis gravidarum or gestational diabetes. We know how to diagnose problems in those physiologic stages and try to help them. But when menopause was seen as, well, if hormone therapy for many people is going to cause you more risk than benefit, then maybe you're just better off to try to manage this. That meant then that doctors kind of stopped asking about it. People stopped telling their doctors they were having symptoms. And so menopausal training just kind of, I think, fell by the wayside. And it's a shame because it's really not that difficult to do an academic half day that teaches people the basics about menopause. The trick is that people come to that now still with preconceived notions. I give talks all the time to family doctor groups, nurse practitioners, etc., and they believe me when I give them a 1 or 2 hour talk about, what happened in the WHI, what the truth actually is, what the benefits of hormone therapy are. And they'll say to me like, holy smokes, that was more menopause information than I got in, 6 years of medical school and my residency training. So it would not be difficult for us to decide to pick up this torch and say, you know what? A menopause academic half day is now going to be happening in every single medical school, every single family practice program, every single OB-GYN residency. And it should actually be happening in cardiology, in endocrinology, in every program, because we know now that menopause affects every body system. And so we need the will for that to happen. And we need the people who are organizing the academic schedules to decide that that's important to slide in there. Even if that means kicking something else out, right? So that's where we need to get more training.
Well, I think that nowadays menopause is not like that dirty word that nobody speaks of. And so creating awareness is, that's what you're doing. That's what we're doing. So maybe in the future for our daughters, even for us, hopefully, things will turn around. But it's so interesting how, and I really want to speak about how menopause is really the new cash cow, but how you kind of gave some background as to how it became the cash cow with that WHI study. So let's kind of get into that a little bit more, because we really need to clear up the misunderstandings over synthetic, bioidentical, those types of topics.
Yes. So first off, terminology, hormone therapy, HT, is a good term to use, for the umbrella for all of this. There is a difference between Canada and the UK and such, where we tend to use menopausal hormone therapy, MHT, as the acronym for this, because it's meant to represent the honesty that this is a menopausal, because you're in menopause, you're low estrogen, hormones, because we're giving you hormones as therapy. Therapy meaning you have something we're trying to treat, namely symptoms or increased risks, right? In the UK, they are still using the term more of hormone replacement therapy, which, there's a slightly different vibe going on over there. There's a little bit of hormone evangelism going on as well. Hormone replacement therapy is a really good term to use when women are young, when they've had their ovaries removed, or when they're going through premature menopause, so that we really are trying to replace and give back hormones that they should be having at that age, right? But when you go through the natural state of menopause, again, a lot of people who've had horrible symptoms really feel like they are wrong, that there's something wrong, that their body is off, that they cannot function. Like there are severe symptoms of menopause. And so those people really feel like they have a dysfunction, a hormone deficiency. They talk about wanting to get their hormones back, their self back, their hormones replaced. And so, there's a little bit of kind of word manipulation that happens in all of this, because we need to let people who have horrible symptoms feel justified in the benefit of using hormones to treat their symptoms. But we're not replacing them, truly. When we're giving menopausal hormone therapy, we're giving extremely low doses in a steady state. This is nothing like what you used to make when you had menstrual cycles, right? And remember that menstrual cycles themselves actually had some people suffering, right? And having problems, endometriosis, horrible PMS and PMDD, fibroids, and horrible bleeding periods. Like natural cycles themselves can be a difficulty, right? So the goal of menopausal hormone therapy is to be a very low, very, safe, very sustainable dose that you can use for years, because menopausal symptoms can last for years, right? So the concept of wanting to make this as safe as possible is a fair one, because some people might need to use it for a long period of time. And that's where this bioidentical concept comes in, that is really, really tempting, right? And the bioidentical marketing came out as, you want things that are just like what your ovaries used to make, that are individualized to you and exactly what your body needs. We'll use a bunch of blood tests to tell you exactly if you're in the right range, that these are coming from plants, that they're natural. That's all a bit of exaggeration, right? All pharmaceuticals are semi-synthesized at minimum, right? So yes, you might start with something that is coming from a yam or a plant or a soybean product, but it has to go through a heck of a lot of chemistry modifications in a lab in order to become estradiol in its chemical composition, right? Estradiol is what your ovaries make when you're ovulating. So it's not bioidentical in that we're not actually harvesting it from you or from other humans. We are still synthesizing it. Think of like vitamin C tablets. You get a big bottle of vitamin C, ascorbic acid. There isn't someone somewhere squeezing a whole bunch of oranges in order to give you vitamin C tablets, right? It has to be chemically created. Same thing with melatonin. It's chemically created to be the structure of something that will interact with your receptors similarly to the way your own estradiol did. Okay? And that doesn't itself make it necessarily safer or better. It just makes it different. Conjugated estrogen, Premarin, has been the most studied hormone therapy that's been around for the longest period of time. And the long-term follow-up of the WHI showed that the women who were on estrogen only or Premarin only because they had their uterus removed didn't have more breast cancer. And that is now being quoted a lot as estrogen only therapy will not give you breast cancer. Hold on. That was Premarin only therapy that was being studied. So we tend to crisscross these terms of, to meet our objectives. And it's a fine objective to say hormone therapy overall for a low risk person who's having horrible symptoms is safe and effective and the gold standard for menopause treatment. And that can be estradiol. It can be conjugated estrogen. It can be micronized progesterone, which again is synthesized. It can be the progestins, which are not exactly like what your ovaries used to make when you ovulated. What makes these things safe is that you have a formulation that is reproducible, that you have manufacturing processes that have it to be reliable, that you know that no matter what pharmacy you go to, you can take your prescription for your patch or your gel and it will be exactly the same. And we don't need blood tests for that. We don't need to charge you hundreds of dollars in order to do that. And that is what people are still kind of doing when they're compounding a bioidentical ingredient. So the estradiol itself is a fine component of menopausal therapy. What you don't want is the compounding of it, because that is expensive, not necessary, not as well researched and safe. And so that's where people really need to understand that bioidentical term does apply to things that I prescribe, that any doctor will prescribe, that you could pick up at your Rexall or your Shoppers Drug Mart. That bioidentical means, the chemical formula of the active ingredient that's in it, if we want to use the term appropriately. And there are people who are trying to just get rid of the term, right? I've noticed that there are other gynecologists who are wanting to never use the term bioidentical because they'll say this is a compounding marketing term. Well, we kind of need to just take it back, right? We need to take it back and make it accurate, because in my practice, I turned away consults sometimes when doctors would say, this person wants bioidentical therapy. And I was like, well, they want compounded therapy and I don't compound for the most part. So I would turn those down and say, if your patient wants compounding, they shouldn't come to me. And now I've started saying, well, yeah, actually, I can provide bioidentical therapy too, because I can prescribe it to you as a patch and a gel and the micronized progesterone. So bring it on. Any person who wants bioidentical therapy can get it from their physician.
I think if their physician will deal with them. I was on a coaching call last night with a client in Texas. She went to 4 OB-GYNs that just basically turned her away. And she ended up at a med spa. And she said, look, I did not want to be there. The first thing they offered me was semaglutide. I knew I didn't want that. So then they had these bioidenticals that I had to go to a compounding pharmacy for. And she said, this was my only option. So I
Yeah.
asked for the lowest dose. I felt like if the pharmacists, they're experts. And if something was crazy, I was hoping that they would be at least flagged to be
Right.
like, do you know what you're taking? Because often,
Right. Right.
in Canada, your pharmacist will talk to you. So like what recourse do people have when they have no doctor that will talk to them? And she's spending hundreds of dollars. She's
Yep.
spending
Yep.
hundreds of dollars for blood
Yeah.
tests and compounding.
Yeah. And that's where I think we really need as an evidence-based physician community. We need to get evidence-based doctors reading the evidence base, reading the guidelines. It's not difficult to read. There's been some great articles that are summary documents in the CMAJ, the Canadian Medical Association Journal. There's good publication called the MQ6, which was published by Dr. Susan Goldstein. It's meant to be 6 quick questions that you can ask your menopausal client and can guide you onto how to treat their menopause and prescribe hormone therapy. This doesn't have to be so difficult. We shouldn't be throwing women under the bus because they have gone to 4 different evidence-based doctors who will not listen to them and give them therapy. Like I'm a little bit worried for the physician community that some of those people are going to start getting some blowback about this because they're starting to perpetuate misinformation. It is not accurate anymore for us to continually make women feel like hormone therapy is dangerous and not accessible to them. And if they're choosing it, they are choosing to treat their symptoms at the expense of now going to give themselves breast cancer. It seems like it's a foregone conclusion. And that is grossly inaccurate. And so, whatever it takes for us as a physician community to get the better education out to those doctors, we have to start doing it because now that women are reading the articles, they can access the CMAJ, they can read the New York Times article. It's on the Globe. It's been here in Canada. It's been on every single major major broadcasting network. There's been articles about and interviews. Sometimes, for 15 minutes, there's huge segments on menopause. So women are learning about this and they want to get help. And so if we as a physician community at this point don't pick it up, then they're going to continue going for compounding and buying bottles and bottles of some marketed supplement on the shelf in the drugstore and spending tons of money and not getting help. Like we have to start partnering and realizing that this is knowledge that the physician community can't anymore say, oh, menopause, that's not my area. I'm going to forward you to someone else who knows how to deal with this. We just can't tolerate that anymore.
And I appreciate your passion about it because I can just see like this is like so important to you. And as a woman I appreciate that and the work that you're doing. So thank you, Dr. Piper, for just sounding the alarm and educating and really helping all of us. Who would be a candidate for hormones? Where do we start with that?
Yeah. Well, there are different types of hormone therapy in the umbrella of HT hormone therapy. There's systemic hormone therapy, and then there's the local hormone therapies. So who is a candidate? Pretty much everyone is a candidate for the local hormone therapy, right? There are almost no contraindications except for like having a local allergic reaction or something like that to using a local therapy. So this can be a cream, this can be a tablet, this can be a ring that you place in your vagina. There are daily ovules you can place in there. The ingredients range from being estradiol to estrone to DHEA, and there is still the original conjugated equine estrogen cream. All of those are intended to be local. They are not intended to get into your bloodstream. They're not intended to treat hot flushes, protect your bones. They also then, because they don't get into your bloodstream, don't need a conversation about, let's clarify your breast cancer risk, your heart disease risk, your clot risk. These are local therapies. They work on the tissues where they're making contact. So virtually every woman is a candidate for local therapy. And if I could put something in the water, if I could do anything to wedge into the physician community that there is something that everyone needs to pick up on, it would start with that, right? Because if we can get people realizing how safe and effective those local therapies are, whether it's the public or whether it's the physician community, then that gets us at least becoming comfortable with that concept, right? Because it's been a horrible shame that because of the fear that we've had of conjugated estrogen and MPA from 20 friggin' years ago, that we're not giving women even the local therapies that were not part of that study, that are not systemic hormone therapy. And the symptoms of genitourinary syndrome of menopause, this is what they're treated. So this is the indication for them. Vaginal dryness, difficulty with intimacy, increased yeast infections, bacterial vaginosis because your pH is wrong with your vagina, skin being thin. More bladder symptoms, pain when you pee, itching, bladder infections themselves, vulvar discomfort, vulvar irritation. Genitourinary syndrome of menopause is a huge bunch of symptoms, and it is so easy to treat. You could use moisturizers and lubes, sure, fine. But the only thing that is really going to improve the architecture of your skin down there, bring back some thickness, bring back the vascular flow, let you have, better physiologic discharge, a lower pH that keeps away infections, gets rid of that, helps to improve urgency, helps to improve your sexual function. All of those things are going to be benefited by the local therapy. So that's indicated for virtually everyone, and it's extremely safe.
And when
Indications. Go ahead.
I don't even know when they need that.
Stay tuned for part 2 of our interview with the wonderful Dr. Ardelle Piper, where we will continue to talk about all things menopause and menopause hormone therapy.
Thanks for listening. You'll find me, Alli, on Instagram at Alli Kerr Fitness.
And you'll find me, Shawna, on Instagram at Shawna Kaminski. Feel free to pop us a DM with questions and or feedback. If you're enjoying the Girls Talk Healthy Aging podcast, please subscribe and share it with other health-minded women. Ratings and reviews are also much appreciated and help us get our message out to a larger audience.
Until next time, be healthy and be happy.